Laryngopharyngeal reflex caused by backflow of gastric contents into the upper aerodigestive tract, leading to symptomatology of the larynx, esophagus, and upper aerodigestive tract. This entity, first described by Kaufman in 1991. In the esophagus, a degree of gastroesophageal reflex is considered physiologically normal as long as the exposure time does not exceed 5% in 24 hours. Although the esophagus is lined by resilient stratified squamous epithelium, the tissue damage is thought to acid mediated and that is less affecting the esophagus because of this resilient stratified squamous epithelium. While larynx is lined in part of area of very delicate squamous epithelium and rest by the pseudostratified ciliated epithelium, both of which are far less resilient than the esophageal mucosa for the acid reflux. Refluxate, when present, is neither removed by peristalsis nor neutralized by bicarbonate. Tissue damage is thought to be mediated by activated pepsin and can occur very rapidly following exposure times, which may be brief as 30 seconds 3 times per week. So, this less time, like 30 seconds 3 times a week, may lead to this edematous congested vocal fold or laryngopharyngeal reflex. Reflex disease that affect the laryngopharynx is one form of extraesophageal reflex disease. It can affect also esophagus also. That may be erosive reflex disease about one third of the cases, and two-third cases may present with non-erosive reflex disease of the esophagus. And LPR events often occurs in the upright rather than supine position, while the esophageal reflex disease present with erosive or non-erosive form as in the supine position. Although GORD and LPR may exist independently, as disease severity increase, the likelihood of both types being present simultaneously in the esophagus or larynx. Gastric refluxate is often considered solely in terms of acid content, but in addition to hydrochloric acid, it also contains enzymes, notably pepsin, food residues, bile acids, and bacteria. Reflux episode may involve significant volume of liquid gastric contents, particularly in the lower esophagus. But in laryngopharynx, it may mainly gaseous component which lead to LPR. Containing fine aerosol of droplets, such episode may be triggered by transient lower esophageal sphincter relaxations. Once the aerosol has reached to the laryngopharynx, it then passes easily to the nose, nasopharynx, and lower respiratory tract, leading to upper aerodigestive as well as lower respiratory tract diseases. Pepsin is secreted in form of pepsinogen which is physiologically inactive. It is activated by cleavage in acid less than 4 pH. Hydrochloric acid may be present in concentrations that can be affected by medication, notably proton pump inhibitor. Pancreatic protease, especially trypsin, may be present, especially in patients who have gastrectomy or gastroenterostomy or who are taking PPI. Bile acids are mainly in conjugated form, but free bile acids can cause tissue damage, partly digestive food residue and bacteria, notably Helicobacter pylori, may also damage the mucosa. Most patients with LPR are diagnosed on clinical grounds following outpatient assessment including history taking, examination, flexible endoscopy, and sometimes required biopsy of the gastric mucosa. LPR symptom mainly dysphonia, swallowing difficulty, globus or feeling of lump in the throat, throat clearing or tickle in the throat, sore throat, coughing and choking, thick mucus in throat or postnasal drip, and laryngospasm induced cough. These are the symptoms of the LPR. The causes of laryngeal inflammation may be reflux disease, smoking, inhale irritant, alcohol, allergy, virus infections, voice abuse, and bacterial infection. The reflex symptom index can be used as fairly sensitive index to document the reflex diseases. It contains hoarseness or problem with your voice 0 to 5, clearing your throat 0 to 5, excess throat mucus or postnasal drip 0 to 5, difficulty swallowing food, liquid or pills, coughing after you have eaten food after lying down, breathing difficulty or choking episodes, troublesome or annoying cough, sensation of something sticking your throat, heartburn, chest pain, indigestion, and stomach acid coming up. These are the symptomatology to score 0 to 5. Score 0 means there is no problem, 5 means severe problem. If total score more than 10, indicate a problem as LPR, more than 20 moderate and more than 30 is severe LPR scores. According to this reflex symptom index, you can identify it and you can make severity of this LPR. On endoscopic finding, you can make the severity of the LPR. According to the symptomatology of reflex finding score, RFS, having intraglottic edema, ventricular obliteration, arrhythmia, vocal fold edema, diffuse laryngeal edema, posterior commissure hypertrophy, granulation, and thick endolaryngeal mucus. According to that, you can grade from 0 to 4, like 0 absent, mild 1, moderate 2, severe 3, polypoidal 4. If it is more than 7, indicate LPR. Now treatment. First is diet and lifestyle changes. Like you have to quit smoking, reduce alcohol intake, avoid carbonated drinks, reduce caffeine intake, avoid fatty diets, and during night you have to elevate the head. These are the small lifestyle and dietary changes for LPR patients. After diet and lifestyle advice, you can grade this mild, moderate, and severe. If it is mild, then you have to give only alginate about 2 months. Moderate, you can add PPI. If it is severe, then you have to give high dose PPI with alginate and reassess these patients every 2 to 3 months. If these patients are not responding to this medical treatment, then you have to think about the surgical treatment. So, medical treatment consists only PPI and alginate. And you can add, if not responding to this medical therapy, then you have to add anti-reflex surgery like laparoscopic fundoplication so that you can correct the surgical part.